Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Deep Dive. Today's episode is brought to you by the Surgical Edge podcast. Now, because we're talking about something so critical, just a quick mandatory note for everyone listening. This is for reference only. Always follow your local, institutional, and national guidelines. Okay, so we are jumping into necrotizing fasciitis, NF. I mean, for surgeons, this is probably one of the biggest tests there is. Speed, judgment, everything's on the line.
It really is a true surgical emergency.
And what's fascinating, and maybe a bit concerning, is how small differences in protocols, UK versus US, or even hospital to hospital, can impact things so dramatically.
Absolutely. So our goal today is pretty clear. We want to compare the key guidelines, mainly the UK's Four Nations Consensus and NICE, against the US guidelines from SI and IDSA.
Right. And pull out what's universal, but also highlight those subtle differences that might actually matter a lot in practice.
Exactly. NF is thankfully rare, but it's incredibly aggressive, life-threatening, characterized by that rapid, widespread necrosis of fascia and subcutaneous tissue. It needs immediate action. We want to arm you with practical, nuanced insights.
Not just reciting the guidelines, but understanding the why behind them.
Precisely. Getting you to that informed decision point faster when, the clock is really ticking.
Okay, let's unpack this. Diagnosis. This feels like the trickiest bit, doesn't it? That early window is so small.
It is, and everyone agrees. The absolute cornerstone is just having a high index of suspicion. There isn't one single sign that screams NF initially.
So what are the universal red flags, the things that should immediately make you think, could this be NF?
Pain. Number one, without a doubt, across all guidelines. Severe pain that seems way out of proportion to what you're seeing on the skin.
That's the classic description, isn't it? The skin looks maybe like mild cellulitis, a bit red, a bit swollen.
But the patient is describing agony. Excruciating pain, maybe even radiating away from the obvious site. That mismatch is your first huge clue.
And it's often coupled with that systemic hit, right? They're not just in pain, they're sick.
Very sick, very quickly. You see that rapid onset of systemic toxicity, fever, tachycardia, tachypnoea, signs of sepsis, progressing towards shock. You don't typically see that kind of rapid collapse with simple cellulitis.
Then come the skin changes. It's important to know the progression, I think.
Definitely. It starts often non-specifically erythema, swelling, but then quite quickly you might see it change to a sort of dusky purple or even bronze color.
And blisters. Bullae.
Yes. Tense blisters or bullae, often filled with this dark, murky fluid. That's a really worrying sign. And then the late but sort of definitive skin sign is cutaneous anesthesia.
Where the skin actually goes numb.
Exactly. The area is clearly infected, looks terrible, but the patient loses sensation because the nerves in the superficial layers are being destroyed by the necrosis spreading underneath. It's a horrific sign.
Signals deep tissue death. And crepitus, that crackling feeling under the skin.
Crepitus can be there, yes, indicating gas produced by bacteria, but it's often a late finding, and its absence certainly doesn't rule out NF.
Okay, so we have this constellation of signs. Now, here's where the guidelines seem to diverge a bit in their approach, particularly with scoring systems. The UK puts quite a bit of stock in the anaerobic score.
They do. The Four Nations guideline really highlights the laboratory risk indicator for necrotizing fasciitis. It uses common lab tests, CRP, white cell count, hemoglobin, sodium, creatinine, glucose to generate a score.
And what are the numbers clinicians should know?
Well, the guidance suggests a score of 6 or more should raise significant suspicion, prompting rapid action. A score of 8 or higher is considered strongly predictive of NF. It gives a kind of objective measure to back up clinical suspicion.
But the U.S. guidelines, like from IDSA, seem less enthusiastic about anaerobic.
Yeah.
Why is that?
I think it stems from studies showing variable sensitivity. Sometimes it's just not that accurate, especially early on. You could have raging NF, but the LYNX score might still be low.
So waiting for the labs to hit a certain number could actually be dangerous.
That's the concern. The U.S. approach really emphasizes that clinical picture. The pain out of proportion, the systemic toxicity. If those are present, that's your trigger, regardless of the score.
And the crucial point for both, really, is that a low LYNX score absolutely does not rule out NF.
Cannot stress that enough. Clinical judgment remains king. Anaerobic is an adjunct, maybe helps stratify, but it shouldn't stop you acting if you're worried.
So it's interesting. The UK leaning on a score, the US more on pure clinical gestalt. but both leading to the same urgent action if suspicion is high.
Exactly.
Oh, so suspicion is high, workup needs to happen like yesterday, but it can't delay definitive treatment. What are the absolute immediate first steps?
Two things simultaneously. One, resuscitation. These patients are profoundly septic, often massively fluid depleted from third spacing. They need aggressive IV fluids right now.
And two,
antibiotics. Broad-spectrum IV antibiotics. Get blood cultures first if you can do it quickly, but those antibiotics need to be going in within the first hour of suspicion. That golden hour concept is absolutely critical here.
non-negotiable. And what about blood tests beyond the LRX components? What else is essential immediately?
Full blood count, UNEs, CRP, liver function, clotting screen, definitely cultures. But crucially, group and save, or even better, cross-match blood immediately.
Because they bleed.
They often require massive transfusions during surgery. You need blood products ready before they hit the operating table.
Right. Now the imaging question. X-rays. CT scans. There seems to be a bit of a difference here too.
Yeah, plain x-rays might show subcutaneous gas, which is suggestive, but they're pretty insensitive overall. CT is much better. It can show gas, fluid collections along fascial planes, fascial thickening. Very sensitive.
And the U.S. guidelines seem perhaps more inclined to use CT if the diagnosis isn't completely clear.
Possibly, yes. If there's diagnostic uncertainty, a quick CT might be considered useful.
But the UK guidelines sound a strong note of caution here.
They do. A very strong warning that imaging should never delay surgical exploration if your clinical suspicion is high. Think about it moving a critically ill, unstable patient to the CT scanner, waiting for the scan, waiting for the report. That's potentially an hour or more lost.
An hour you don't have.
Exactly. If the clinical picture fits, the UK mantra is basically get them to theater. Surgical exploration is both diagnostic and therapeutic. It's the gold standard.
So the knife is the ultimate diagnostic tool here.
In many cases, yes.
Which brings us to management. We've got the resuscitation going, antibiotics started, now surgery. Let's talk antibiotics first, though. The specific regimens differ.
They do, mainly driven by local resistance patterns. You need broad cover, gram-positives, gram-negatives, anaerobes. The typical UK regimen is often something like IV benzyl penicillin, plus IV clindamycin, plus IV piperacillin obactam, or maybe a carbapenem.
And clindamycin seems to be in almost every protocol, UK or US. Why is it so important?
Clindamycin is vital, not just as an antibiotic, but because it actively suppresses toxin production by bacteria like group A strep and Staph aureus. Even if the bug shows some resistance to Clinda on paper, that antitoxin effects can be life-saving in terms of reducing systemic shock.
Okay, that's a key point. Now, compare that to the typical U.S. regimen.
The U.S. guidelines, like IDSA, often start with IV vancomycin or lanazolid for gram-positive cover, again with piperacillin tazobactam or carbapenem, and also clindamycin.
So the big difference is Vam aureus or lanazolid instead of benzyl penicillin. Why?
It reflects the significantly higher prevalence of MRSA methicillin-resistant Staph aureus in many parts of the U.S. compared to the U.K. They need that MRSA cover built in from the start empirically.
So crucial takeaway for clinicians listening. Know your local bugs. Your hospital's antibiogram and MRSA rates should guide that initial choice.
Absolutely. But regardless of which specific drugs you choose, the surgical principles are the same everywhere. And they are aggressive.
Describe that first operation. What's the goal?
Urgent. Radical debridement. Simple as that. You have to control the source of the infection. This means cutting away all dead, necrotic tissue, skin, fat, fascia, sometimes muscle, until you reach healthy tissue that bleeds and looks viable.
And the incisions can be huge, right? Far beyond the initially apparent skin changes.
Often shockingly extensive. You follow the plane of necrosis wherever it leads. Hesitation is fatal. Afterwards, the wound is almost always left open, packed, and very often a negative pressure wound therapy or VAC dressing is applied.
To manage, exudate, and promote granulation.
Exactly, and control contamination. But the surgery doesn't stop there. There's the mandatory second look.
Right. Back to the OR within
12 to 24 hours, no exceptions. You go back, inspect everything, and debride anything else that has died off or looks suspicious.
And you keep doing this.
You repeat it, sometimes daily, until you are absolutely certain that the infection is controlled and there's no more necrotic tissue. Stop debriding only when you find healthy tissue throughout.
Okay. Now, for probably the starkest difference in the guidelines, hyperbaric oxygen therapy, HBO. The U.S. mentions it. Sometimes.
Yeah, the U.S. guidelines tend to list it as a potential adjunct therapy, something that might be considered often depending on the specific institution and maybe particularly for infections caused by gas-forming anaerobes like Clostridium, but it's usually framed as maybe helpful, not essential.
Whereas the UK stance is pretty blunt.
Very blunt. The UK Four Nations guideline explicitly advises against using HBO for necrotizing fasciitis.
Wow. Not just not recommended, but actively advised against. Why such a strong position?
Two main reasons cited. First, they argue the clinical evidence supporting its benefit in NF is weak or inconsistent. They don't feel it clearly improves outcomes like survival or limb salvage rates.
Okay, lack of strong evidence. What's the second reason?
Logistics and risk. Transferring a critically ill, unstable patient, often intubated and on multiple infusions, to a separate HBO chamber facility. It takes time, involves risks, and critically, it potentially delays the next essential surgical debridement.
So the risk of delaying the definitive treatment outweighs any potential unproven benefit of the oxygen chamber.
That's the UK position, essentially. The priority is aggressive surgery, repeated as needed, without interruption. HBO is seen as a distraction with questionable benefit. Access to chambers is also much more limited in the UK.
That's a really clear divergence based on evidence interpretation and risk assessment. Okay, let's assume the patient survives the initial onslaught, the debridements are done. What happens next in the post-op phase? It's still a long road.
A very long road. Usually starts in the ICU. Focus shifts to ongoing resuscitation, supporting organ function, kidneys, lungs often requiring inotropes, ventilation, and nutrition is key.
They need huge amounts of calories and protein to heal those massive wounds.
Immense amounts. Enteral feeding through a tube into the gut is preferred if possible, starting early. Antibiotics are continued, usually until after the final debridement, and the patient is clearly improving systemically, fever settling, inflammatory markers coming down.
And managing the wound itself. The VAC dressing often stays on for a while.
Yes, VAC therapy is incredibly useful for managing these large open wounds. It helps control fluid, reduces edema, protects the wound, and encourages healthy granulation tissue to form, preparing the bed for closure.
Which brings us to reconstruction. How do you close these massive defects?
Once the infection is totally controlled and the wound bed is clean and granulating, you have options. Sometimes smaller areas might heal by secondary intention, just letting them fill in slowly. But most commonly, it requires split-thickness skin grafting, STSG.
Taking skin from another part of the body to cover the defect.
Exactly. It's the workhorse for covering large areas relatively simply. But sometimes a graft isn't enough.
When wouldn't it be?
If the debridement has exposed critical structures like bone, tendons, joints, or major blood vessels, a simple skin graft won't survive on those or won't provide durable coverage.
So then you need something more complex.
Then you're into the realm of flap reconstruction, bringing in thicker tissue with its own blood supply, either from nearby areas, a local or regional flap, or sometimes from distant sites using microsurgery, a free flap. That often requires specialist plastic surgery input.
Okay. And finally, the long-term picture. We save the life, we save the limb, maybe we reconstruct the defect, but the impact doesn't end there.
Not even close. The physical recovery alone is incredibly demanding. It requires a huge multidisciplinary team effort, physios, occupational therapists, tissue viability nurses, often months, sometimes years of intensive rehab just to regain function.
But the sources really emphasize the psychological scars too.
Profoundly. This is a massively traumatic experience. Patients have faced death, endured multiple painful surgeries. They're often left with significant disfigurement, chronic pain, altered body image.
Sounds like a perfect storm for mental health issues.
It is. Studies show really high rates of post-traumatic stress disorder, PTSD, sometimes approaching 50% of survivors, plus significant levels of depression and anxiety.
So psychological support isn't just a nice to have, it's essential.
Absolutely essential. Access to psychologists, psychiatrists, mental health support needs to be a standard integrated part of the long-term follow-up care pathway, just as much as the physiotherapy. We need to treat the whole person, the survivor, not just the wound.
That's a powerful point to end the detailed discussion on. So if we synthesize all this, the core message seems consistent globally, right?
Absolutely. Early suspicion, aggressive fluid resuscitation, immediate broad-spectrum antibiotics, and urgent, radical, serial surgical debridement. Those are the universal pillars. Get those right quickly, and you give the patient the best chance.
The surgeon's willingness to act decisively, maybe even when things look deceptively benign initially, is probably the single most important factor.
Couldn't agree more. Hesitation kills. But clinicians do need to be aware of those nuances we discussed. The UK's reliance on Ellerneck versus the US focus on pure clinical signs. The antibiotic choices driven by local MRSA rates, and that stark difference regarding HBO.
The UK explicitly saying no, the US saying maybe sometimes?
Right. Knowing these differences helps you understand the rationale behind your local protocols, or perhaps question them if needed.
Which brings us to a final thought for you, the listener. Given this international variation, particularly around adjuncts like HBO, how do you effectively weigh a potential, maybe unproven benefit against the very real, proven risk of delaying definitive surgery? Especially if using that adjunct means moving a critically ill patient or pulling resources away.
Yeah, that's something worth considering when you review your own unit's approach. How do you balance guideline recommendations, local resources, and the absolute priority of getting that patient to the operating room?
Food for thought indeed. Thank you for joining us for this deep dive into a truly challenging surgical emergency.
Thanks for listening.
We'll see you on the next one.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.